My name is Lisa Wilsbacher. I am an associate professor of medicine at Northwestern University, and I am a physician scientist with expertise in genetic cardiomyopathies. Within my clinic, I'm part of a cardiovascular genetics clinic, and I see patients who have dilated cardiomyopathy, hypertrophic cardiomyopathy, and arrhythmogenic cardiomyopathy. And we use family history, clinical information, and genetic testing to help define the causes of cardiomyopathy in individuals and in families. Today, I'll be covering the aspects of cardiomyopathy that's caused by mutations in the LMNA or LMN gene. The first question that I will focus on are the unique characteristics for people who have LMN cardiomyopathy. Now, as you are very well aware, I'm sure, LMN can cause a cardiomyopathy that leads to reduced ejection fraction and symptoms of heart failure. And as a matter of fact, LMN accounts for 5 to 10% of all genetic dilated cardiomyopathy. It's the second most frequent gene where we find pathogenic variants, otherwise known as mutations. And in addition, it is one of the genes that can lead to a high risk of arrhythmias. And so those are the groups that we call arrhythmogenic cardiomyopathy. One of the unique features of LMN cardiomyopathy is that in most cases, the symptoms begin with either arrhythmias or with cardiac conduction abnormalities. Cardiac conduction means the electrical impulses through the heart that trigger the heart to beat. Some of the arrhythmias that we often see include atrial fibrillation, and it may be at a fairly low heart rate compared to other people with atrial fibrillation. There can be a slow heart rate at baseline, even when the heart is in normal rhythm. And then some of the conduction abnormalities that we observe include heart block, meaning that the rate that the electricity gets through the heart is slowed compared to normal. This can become severe enough that a pacemaker may even be required. And again, uniquely in LMN cardiomyopathies, these types of arrhythmias and cardiac conduction defects tend to happen either as the heart is starting to dilate or even before the heart has dilated. And then when we meet a patient who has these types of specific arrhythmias, and that we start to see that the ejection fraction is mildly decreased on an echocardiogram, that starts to trigger the suspicion for a LMN cardiomyopathy. Furthermore, LMN can be associated with ventricular arrhythmias, some of which can be life-threatening. And again, these can precede overt heart failure. Another relatively unique aspect of LMN cardiomyopathies is that the skeletal muscles can also be affected. And in some cases, it is appropriate to refer a patient to a neurology and specifically a neuromuscular clinic. Now, moving on to the second aspect of what I wanted to discuss today, and that was the question about what is the disease process for LMN cardiomyopathy and what are the treatment options that are available. So I've already touched a little bit on the disease progression. Again, most frequently, we see patients first presenting with arrhythmias, atrial and ventricular arrhythmias, and cardiac conduction defects. And these can become progressively worse over time to the point of even requiring a pacemaker if the heart rate is too slow. During this time frame, then the ejection fraction often will decrease, and then those symptoms of heart failure may develop, including feeling shortness of breath or having swelling in the ankles or abdominal fullness. One of the most important aspects in LMN cardiomyopathy is to determine the risk of a life-threatening arrhythmia. And we have several tests that we can do to help stratify that risk. This includes EKGs, Holter monitors, an echocardiogram, and then a cardiac MRI. Often on a cardiac MRI, we may see scar tissue or late gadolinium enhancement. And this is represented by having a stripe of a white colored material inside what is supposed to be the dark color of the heart muscle itself. These areas of scar tissue are where the ventricular arrhythmias can arise. And if there is a very high burden of this scar tissue in the heart muscle, then that increases the risks of ventricular arrhythmias. In terms of assessing for those life-threatening ventricular arrhythmias, there are some features that if they are noted in the workup, then that would mean that an implantable cardioverter defibrillator, or ICD, would be the right course of action for that patient. One of the factors is if the ejection fraction is less than 45%. This is actually a higher ejection fraction than for most cardiomyopathies that would trigger the need for a defibrillator. Other risk factors include male gender and having a history of non-sustained ventricular tachycardia, or NSVT, on your Holter monitoring. And then if there's any indication for needing a pacemaker, then the recommendation would be to put in a defibrillator, which has the pacemaking components with it, because the risks of those life-threatening arrhythmias is so much higher. We have guidelines from both the American Heart Association and American College of Cardiology, as well as from Europe, that help to outline where and when should we be thinking of a defibrillator in patients with LMNA mutations. And in fact, the European guidelines take advantage of a particular risk calculator that is available for clinicians to use to help estimate what the risks are for arrhythmias in the next 5 years. Those guidelines even recommend that if the 5-year risk of a life-threatening arrhythmia is estimated to be more than 10%, and that there are other specific risk factors that are present, that a defibrillator should be discussed with the patient. Now, as I've mentioned, with LMNA cardiomyopathy, heart failure can develop as the ejection fraction goes down. And there are very well-established guidelines for medications to use in the setting of heart failure with reduced ejection fraction. These medications include beta blockers, angiotensin receptor blockers, and neprilysin inhibitors that are combined, mineralocorticoid receptor antagonists, and then SGLT2 inhibitors. And in many cases, we do recommend being on all of these medicines to help maintain heart function at the highest level possible for as long as possible. Another important aspect for the medical management in LMNA cardiomyopathies is for atrial fibrillation. We recommend anticoagulation or blood thinners to help prevent the risk of stroke. There are other risk calculators that clinicians use for atrial fibrillation in people who do not have a LMNA mutation. But with LMNA mutations, no matter what that other risk calculator says, we still recommend that patients be on blood thinners because the likelihood of developing a blood clot is higher independently of some of these other established risk factors. And then for some patients, when we are talking about the possibility of skeletal myopathy, there is a blood test called creatine kinase that can be used. And if we do see an elevation in creatine kinase, this is an indicator of there being some muscle damage as well. Those are the patients where it may be appropriate to refer to the neuromuscular clinic. And finally, LMNA is an autosomal dominant gene. This means that out of the 2 copies of the gene, one that was inherited from the mother and the other from the father, having just 1 copy with a pathogenic variant or mutation, that's enough to increase the risks of developing all of these features of LMNA cardiomyopathy. This means that first-degree family members are also at risk, and that we do recommend that first-degree family members either undergo cascade genetic testing. That means being tested for the actual pathogenic variant that was found in the first family member. Or if family members prefer not to undergo genetic testing, then to have very regular clinical screening with EKGs and echocardiograms at least every 3 years. One of the last aspects for today was the question of the outlook for future therapies, and especially including genetic cardiomyopathy therapies that are available now and in the future. And, this is an area of very, very intense clinical, basic science, and translational research. For the LMNA cardiomyopathies, we had a signal of a particular inhibitor of MAP kinase inhibitor. This is a signaling protein within the cells in the cardiomyocytes, and the phase 2 clinical trial had appeared favorable. Unfortunately, the larger phase 3 clinical trial did not show benefit of this agent for LMNA cardiomyopathy. There was no harm, but there was no benefit, and so that clinical trial has been stopped. In the research realm, there are many groups that are developing tools for actual gene therapies, including editing of genes. Now, this is something that is still many years away from clinical practice, but we do hope to have this as a potential therapy at some point in the future. And again, it's an area of very intense research at this stage. So to summarize, LMNA cardiomyopathy, it has the unique features of arrhythmias and cardiac conduction disease, often being the first presenting feature of the cardiomyopathy. Patients with LMNA cardiomyopathies should get regular assessments with EKG, Holter, echocardiogram, cardiac MRI to assess for the risk of life-threatening arrhythmias. And ICD therapy is a frequent therapeutic use in patients with LMNA cardiomyopathies. We also use guideline-directed medical therapies to treat reduced ejection fraction, and family members should be screened since they are also at risk for this cardiomyopathy. Thank you very much.
This video is part of a series of educational videos developed by the Genetic Cardiomyopathy Awareness Consortium and brought to you by the DCM Foundation. Our goal is to connect you with the leading experts in the field of cardiomyopathy to further your understanding of this disease and to provide resources to help you manage your care. Thanks for watching.